Okay, so good morning. Welcome everybody to week 7. I think I've officially called week 6 reading week. So we just kind of skipped over week 6 and onto week 7. Today's topic is the sociology of infectious disease. And we'll talk about what all of that means. So just a quick recap of where we left things off before the reading week. So we were discussing the history of infectious diseases. We talked about the epidemiologic transition, which was mostly happening in sort of higher income nations compared to lower income nations. And this week, the focus is on socioeconomic health determinants. So a lot of that has to do with sort of the development, the economic status of countries, but also personal individual incomes, personal economic situations. And so we'll talk about that today and tomorrow. Today's focus is on infectious diseases mostly, whereas tomorrow we'll be tackling chronic diseases, something that we will call chronic diseases of affluence. So we'll talk about that tomorrow. But essentially, when we're talking about these socioeconomic health determinants, we're really talking about things like income, employment, education, these various social economic conditions or factors that play a role on health, people's health. And so this figure was taken from the reading from this week. And I think it's just helpful to sort of contextualize what it is that we're talking about when we talk about socioeconomic determinants of health. And so this is a similar sort of figure to the socio-ecological model that we've been talking about in this course. And it's just hopefully useful to wrap our heads around all of these different factors and how they all play a role on health, how they all kind of are interconnected and play a role together. So what we mean, well, we're talking really about these types of social and economic conditions that individuals find themselves in, but that also play a role on the broader society and society's interactions between individuals. And so a lot of these factors shape people's health in many different ways. They impact our biology, they impact our behavior, they impact our exposure to environmental or workplace hazards, and of course, they impact our access to medical treatments, medical care. And so we'll talk about some of those different things today. Now, to start us off, I want us to take a quick moment to reflect. Who is actually impacted by these socioeconomic factors and why? And are the impacts equal? So what do you guys think? When we're talking about these socioeconomic factors and these determinants of health, what populations or what groups of individuals are we generally most concerned about? And why? So Lisa says the most heavy impact is on low-income groups. Nicole says lower income families, marginalized communities, impoverished communities, everyone who lives in society is impacted, but more so the low income and marginalized. Abby says minorities. Yeah. Yeah, so I think you guys have the right idea here. And I noticed that you guys are using a lot of the terms that I'll actually go and define. So that's good. Hopefully a lot of these concepts will be familiar to some of you, but maybe they'll be new to some other folks. Mariamna says 100%, I don't think it's equal because every family social group has their own circumstances regarding income and jobs. Yep, absolutely. So yeah, the impacts are not so equal. In fact, over the course of today's lecture and tomorrow's lecture, we'll really take a look at some of those vulnerable and susceptible groups that we usually focus on when we talk about socioeconomic determinants. So before we get into all of that, it's probably a good idea to actually define some of these concepts, especially for people who maybe aren't as familiar with a lot of these different terms. So specifically today's topic, sociology of infectious disease. Well, what is sociology for those of us that maybe aren't that familiar? It's the study of society and different social interactions between people. And so this is important because medicine and public health are social institutions, right? think about that for a second, there's many different players involved in the delivery of care or the prevention of disease. So for public health, there's many different organizations and groups of people that are involved with either diagnosing a disease or preventing or treating a sickness. And so the care and containment of both chronic and infectious diseases are delivered through various organizations that have to interact with one another. And the treatment and eradication of these diseases also requires social or societal mobilization. So they require different organizations and groups of people to actually work together to figure out plans, to figure out policies on how to tackle these various different diseases. And so that's what we mean by sociology of disease. It's really trying to capture all these different groups and individuals that are involved in this broader health kind of economy or sector. So it can get a little bit complicated, but I think that's worth noting or worth sort of distinguishing. Now, some other kind of core definitions or concepts to take away for today's lecture and tomorrow's lecture, and some of you actually use these terms, so that's good. Hopefully they're familiar, but maybe you don't even necessarily know fully what they mean or what they capture, and so we'll go through that. So deprivation is an expanded measure of poverty that includes both a lack of social and material goods. So it's different from poverty, which is really focused on something like income. Deprivation tries to capture more of these different factors that are important for socio-economic determinants. So it takes into account something like residential instability, which is something like home ownership or the frequency of changing your address. So that would be considered unstable residential instability. It also factors in economic dependency, so whether or not someone might be using social assistance, what their employment status would be. It also includes ethnocultural factors, so something like a visible minority status, especially if you're living in a neighborhood with a high percentage of visible minority status folks. Your knowledge of languages is also important here, as well as your situational vulnerability. So for example, whether you've attained a certain education by that point in time. Now, another kind of key word is marginalized. And I think it's used quite frequently in conversations, especially in conversations about health, certainly about COVID. It's come up a lot. But I think it is worth really defining what we mean by when we say marginalized. So it's specifically talking about populations that experience exclusion and discrimination in a society. And it's most often used to describe, certainly in the North American and European context, it's used to describe sort of this non-white, non-European heritage individuals or communities that are really lacking the social, economic, and political power in those societies where the dominant power is these white people of European heritage. And so that's what we mean by marginalized. It is worth sort of highlighting what that might mean in the context of somewhere like North America. Now, structural inequality is another one of those really important words. And so what we mean by that is that it's when some people are awarded or attributed an unequal status in relation to other categories of people. And so their secondary status might be due to social, legal, economic, or political institutions. And these are, these structural conditions. It's not the way that people perceive them necessarily, but it's so embedded in the social structures of a society. And that's what social or structural inequality is all about. So another important word that I think is used a lot when we are discussing some of these topics is health inequalities. So health inequalities are differences in health between groups that can arise due to structural, so due to societal factors, or due to individual level factors. So an example of an individual level factor could be something like age, right? There's differences in health between different age groups. So that's a health inequality. However, something like different health status between different ethnicities, that would be more of a structural health inequality. It's not something that an individual can control by any means. And it's also not something that will change with something like age that changes over time. So these health inequalities, well, they make so that different individuals are susceptible to infectious diseases differently, right? Some populations are going to be more at risk of a disease than others. Certainly, we could say that higher aged individuals are more susceptible to something like COVID. So that's an example of this susceptibility of disease being different due to health inequalities. You could also talk about vulnerability. And so health inequalities means that different individuals might be vulnerable to disease transmission. And what that means is that, for example, some populations are more likely to be in contact with pathogens. So again, in the context of COVID, certain workers, particularly racialized workers that maybe are working certain types of jobs more frequently, are the ones that are coming into contact with COVID more frequently. And so that's how some of these factors play out in the real world. Now, another important term is health disparities. And often health disparities are used interchangeably with health inequalities, but they don't actually mean the same thing. So I think it's worth highlighting here. So health disparities are indicators of health inequality, but they are specific in that they adversely affect groups of people who have systematically experienced greater social or economic obstacles to health based particularly on their racial or ethnic group, their religion, their socioeconomic status, perhaps sexual orientation, all these other potential factors. But these factors are ones that are historically linked to discrimination or exclusion. So that's different from health inequalities, which is just any inequality in health, right? It could be due to individual or those structural factors that we talked about, whereas health disparities are really focusing in on those sort of structural factors, so specifically linked to historical discrimination or exclusion. So taking a look at this graph on the slide, it shows COVID-19 death rates in the US by age categories. Do you guys think that this would be an example of a health disparity? Reed says no. Anyone else have an opinion or disagree with Reed? Sunima says no, just a health inequality. Nope, says Rebecca. Okay, good. Yes, so I'm glad that that is clear. So again, age would not be an example of health disparity because it's not one of those factors that we can historically link to this structural discrimination or exclusion from society. On the other hand, something like race would be considered a health disparity. In fact, it's been fairly well studied now in the context of something like COVID, that a lot of these racialized communities do have a higher burden, higher prevalence of the disease. So specifically in the US, unfortunately, we don't collect a lot of race-based data in Canada, so we can't say whether these relationships exist with as much certainty here, but certainly in the US, it has been pretty well documented and well established that Black communities, African American communities in the US disproportionately are affected by COVID, as well as other individuals or communities such as American Indians, as well as Hispanics or Latinos in the US. So that would be an example of a health disparity. Now, we can also observe these health disparities at different scales. Simnima says, why don't we take race-based data in Canada? It's pretty diverse too. Yeah, that's a good question. Unfortunately, the way that health data is collected in Canada, it's done at the province level, and that kind of automatically introduces some challenges that I think are unique compared to the States, where health data is actually coordinated by the CDC, which is a federal agency. And so they just have a lot more kind of control over what data gets collected over the entire span of the country. Whereas I think here in Canada, it would probably result in a bit of a patchwork of different disease collection policies. So for example, Toronto, where I live, Toronto has started to collect a lot of this race-based data just because I think they see the value in it. But there's not as much sort of top-down control over who gets to decide what kind of data gets collected. It's perhaps not seen as a priority in Canada, in fact, because we have a different view on health and we tend to I guess, prioritize equal access. And so maybe we've kind of created this false impression that these health inequalities don't exist here, which of course they do. It's pretty obvious that they do to anyone who has had a chance to look at some of this data. But yeah, so it's not so much that the race-based data doesn't exist, it's just that it is such a patchwork of different places that have decided to collect it versus somewhere in the States where it's really this national policy that allows it to take place. So hopefully that's clear. But yeah, absolutely, we should be collecting this kind of data. In fact, we could do a lot more important research with it if we did. So back to this slide. So hopefully it's kind of easy to notice here, this collection of nations here from Africa. And so this is a graph of the prevalence of viral diseases as well as the GDP per capita. So what would be suggested from this kind of graph is that obviously the lower you have GDP in a nation, the higher prevalence of diarrheal diseases. And I think we've talked about this over the course of the last couple of weeks prior to Reading Week, this link between, low GDP, low development in a nation, having all sorts of impacts on things like infrastructure and safe drinking water, safe sanitation, and things like that. Now, this could be considered something like a health disparity because you'll notice that a lot of these nations are also ones that were previously under colonial rule. So they were countries, by and large, that had a European presence in them prior to sort of World War II. And so in a lot of cases, it was the European colonizers who did establish some forms of sanitation systems or safe drinking water infrastructure, but it was mostly isolated or segregated from those local populations. And so in many cases, once those colonizers left, they either destroyed a lot of that infrastructure that was in place or just never taught the local population how to effectively use it. And so for many reasons, these countries continue to be plagued by a lot of those types of pathogen-related diarrheal diseases, particularly among children and other vulnerable populations. Now, if this sounds a little bit familiar based on what we were talking about with the boil water advisories a couple of weeks ago, then yes, hopefully that does ring a bell to some of you. Because health disparities could also be talked about in the context of First Nations and clean water access here in Canada. So this is a map of Saskatchewan, and every dot there on Saskatchewan represents a First Nations reserve. And so what does it show? Well, that about 3/4 of the First Nations reserves have water and wastewater systems that would be considered either high or medium risk to health. So what does that mean? It means that most of these, or 3/4 of these First Nations reserves, are not able to safely access drinking water on reserve. They'll have to either boil the water or maybe only use it for certain purposes like laundry versus using it for something like food preparation or drinking. And so this is a classic example of another health disparity because it is specifically kind of targeted at that community, which has faced a lot of systematic discrimination and marginalization here in Canada. Now, another really, really important socioeconomic factor that I think most people are quite aware of and its impacts on health is income, of course. And so we can think about income in two different ways. Personal income would be one. So individual incomes, obviously, the more money an individual has, the more that they'll be able to spend on goods and services to maintain their good health. So you could think about that from the perspective of gym memberships or buying nutritious food, maybe having access to better housing because your personal income can afford you better housing. But you can also think about this from the perspective of national income, so GDP. And so a more rich country, a more developed country will generally have more taxable income because more people are working, they're making higher incomes. And so the state is able to collect tax on that in order to spend that money on developing healthy infrastructure, things like safe drinking water and safe sewage sanitation. So this does, however, require people to be healthy enough to work and also for this sort of more sophisticated system to be in place in order to set up taxes and be able to use those taxes in a non-corrupt way and be able to actually implement a lot of these types of infrastructures. So this is an interesting graphic that I found in a study that was comparing stool samples among school-age children in Nepal, so specifically in Kathmandu, the capital city of Nepal. And Nepal is a country located in the Himalayas. So if anyone knows of Mount Everest, that's where Mount Everest is located. But so the researchers were interested in comparing the prevalence of parasites in the stools of these children, comparing specifically private school children to public school children. Sunima says, I grew up in Kathmandu. Oh, interesting. Okay. So you might be particularly interested in this study if you go find it after today's lecture. So in any case, they were interested to know specifically how the prevalence of parasitic infections might vary, and so why that might be. And so I want to ask you guys, it's pretty obvious from this graph, the private school kids are in the black compared to the public school kids here in blue. And so public school age children, they found, did have a pretty significantly higher prevalence of parasites in the stool samples that they collected. Now, why do you guys think that might be? And what kind of income specifically would be perhaps important to this kind of relationship? So Rebecca says, because private schools have more money, there would be more money to spend on developing healthy infrastructure. So is that an example of personal income or national income playing more of a role? Personal income. Yep. Does anyone think national income might be an important factor in this type of relationship? Possibly for the funding of public schools. Yes, exactly. So national income affects the public schools. Yeah. I think both, because getting to go to private school and the national income because less funds to allocate to public schools. Yeah, that's true, Nicole. So yeah, they're both important. From the personal income standpoint, certainly if a family is wealthier and has more disposable income, then they can afford to send their child to private school, which is more likely to have safe infrastructure in place. It's also likely to have a safe playground. Perhaps they have better meals that are prepared for the children using bottled water, for example. Compare that to public school children, which are unlikely to have the same access to those kinds of healthy infrastructures. Sunima says it's actually that middle income people mostly sent their kids to private school, and more so low income people sent their kids to public school. But in Nepal, public schools don't have very good education. Interesting. Yeah, so from the standpoint of this study, they found that relationship specifically to private and public schools, but you're right. Certainly incomes might vary between those different groups as well. And I imagine that there's quite a bit of difference between one private school to another private school and some public schools between other public schools. But so the national income, as some of you mentioned, is also really important, because the more national income you have, the more taxes that you collect, and the more you're able to establish that infrastructure at a more wide scale. It's not necessarily going to be limited to certain neighborhoods or to certain schools. So that's important to note. Now, I do want to also highlight just the financial burden of these infectious diseases, because it might be tempting to think, well, why doesn't a country just sort of allocate more of its money or more of its resources to fighting these infectious diseases? But the truth is that infectious diseases are really costly to manage and to treat. And once they're endemic in a region, they have a lot of impacts on numerous economic sectors that would really impact a nation's wealth and their GDP. So it kind of becomes this cyclical relationship where they're not able to collect that money because maybe less people are working, maybe there's less tourists coming into the country, as was the case in Mexico during the H1N1 outbreak. But once these infections are in place in the population, then it also becomes really, really costly to treat and to manage these pathogens. And so it just really ends up taking a toll on a lot of these countries that were already not so well off to begin with. They already weren't necessarily high income countries that would be able to adequately tackle and manage these infectious diseases. Now, another really important factor that I think most of us are probably pretty familiar with is housing, and specifically crowded housing with poor ventilation poses a really, really big risk to many different infectious diseases. One of the sort of most well-known examples is tuberculosis, and that is specifically unfortunately experienced by Indigenous people here in Canada. And so the Indigenous population in Canada is one that experiences the most severe housing issues in Canada. And this is specifically true for the Inuit population. Now, does anyone have any ideas why the Inuits might be so kind of disproportionately impacted by these crowded housing conditions? Anyone want to guess what might be happening in, I guess, the more northern communities as well as northern Quebec? So Amber says location. Expensive to bring materials up north. Anyone else? Colder weather. Yeah, these are all factors. Anyone else? Yeah, so I think you guys got most of them there. Government housing standards are also lacking on reserves. Yeah, that's a whole other ballpark. Unfortunately, on reserves, which are more in southern Canada compared to Inuit communities, which are a little bit differently managed in Canada's north. But you're right, certainly among First Nations, their housing stock is differently regulated compared to the general population. And so that would certainly have an impact on reserve communities. But yeah, I think most of you got the idea here with the Inuit communities that, of course, them being so remote, them being located in parts of Canada that often have really long winters, it just provides a whole slew of logistical issues when you're trying to plan or effectively implement any sort of new housing stock in the communities there. There's also not as many skilled laborers that are able to go and set up these houses or set up this these new communities. And so there's a whole host of reasons why there's a housing shortage plaguing these northern communities. Now, what is the result? Unfortunately, Nunavut sees the highest rates of tuberculosis compared to any province or territory in Canada, specifically due to these factors related to crowded housing and poor ventilation. Now, this is because obviously the more individuals from a family that have to be crammed together in a house, the more likely it is for the pathogen to spread to an entire family versus being able to isolate maybe an individual or two that are impacted. There's also naturally less access to doctors up there. And so maybe people aren't getting prescribed antibiotics that they could. And so this really does have quite a few health impacts on the communities in Canada's north. Now, another way of thinking about this housing issue or this housing socioeconomic factor is the lack of housing, and specifically how that might impact the health of homeless populations. So hopefully it's pretty obvious to most of us that pathogen transmission would be a pretty significant factor of infectious disease spread in homeless shelters, just due to the congregate living situation, many people kind of coming in and out and having to live in a crowded area. And so perhaps unsurprisingly, rates of hepatitis, tuberculosis, skin infections are significantly higher among those who experience homelessness, especially among those who are homeless and who also use drugs intravenously. And so that becomes a sort of double burden on their health status. And you can see this in the figure here. So this sort of greenish blue, I don't know what to call this, maybe a teal. That's specifically those who use drugs intravenously, so IDU, intravenous drug user. And so, you know, the proportion of the positive tests for hepatitis is significantly higher among those who use drugs intravenously and who are also homeless. Now, another important factor is obviously the less income you have. We talked about how the less money you'll have on spending for nutritious food. And so malnutrition is a really, really important socioeconomic factor that's really, really closely linked to income. But malnutrition is also a significant risk factor for a lot of infections. And it sort of causes this nutrition infection cycle where malnutrition can cause things like immunodeficiency in an individual. So that can increase someone's susceptibility to infections. But once they have those infections, they also don't have the income necessary to maybe access better food, take time off work to really heal. It might also impact their food intake and result in nutrient loss. And so that can really exacerbate malnutrition even more. And so it really does become this kind of vicious cycle for nutrition and infection. Now, another really, really important factor is, of course, discrimination in health. And discrimination can impact the transmission of infectious diseases due to the isolation of marginalized communities. So remember, marginalized communities are specifically those that are isolated from sort of other dominant society groups. Now, in this example, has anyone heard of the Tuskegee study of syphilis in Black males? It's come up quite a lot, I think, in recent conversations about COVID vaccines and why certain racialized communities might be hesitant to get vaccines, why they might be wary of medical practitioners in general. But for those of us who've never heard of this, I certainly had never heard of this study prior to this past year. So what happened with the Tuskegee study is that in the 1930s in Alabama, the US Public Health Service, so think of that as PHAC, so the Public Health Agency of Canada. In the States, they have the US Public Health Service. And so they started a 40-year experiment in the 1930s, which went on for quite some time, where officials followed 600 rural Black poor men in Alabama. And they enlisted these study members because they had tested all these members and they knew that they had syphilis. However, they never revealed to the study participants that they had syphilis, which is a STI that at the time was not yet treatable with antibiotics. But fast forward a couple of decades, treatments became pretty widely available. However, because the researchers were really interested on long-term impacts of syphilis, they didn't allow the study participants to go access those antibiotics. They didn't even tell those community members that medical treatments were available because these study participants also didn't know that they had the disease. And so not only were they refusing to treat them, but they were also refusing to disclose their disease status. And many of those men went on to infect their wives, their sexual partners, whoever it is that they were interacting with. So this was a really, really just terrible example of how discrimination can impact someone's health very, very directly. These study participants were not awarded many of the luxuries that now we have in place thanks to ethical protocols. But at the time, discrimination had this really, really huge impact on access to treatments, and specifically some of the experiments that were being done on racialized communities, marginalized communities, because they didn't have the resources to kind of fight back or to know any better. So this is also why there does seem to be quite a lot of distrust among particularly Black communities in the American South, but certainly in other marginalized communities all over the world, why there's this distrust in medical practitioners and maybe why they would be hesitant to access care that is being told is good for them when maybe their lived experience has told them to be a little bit skeptical or wary of those treatments coming from doctors. And so this has really had some lasting impacts on generations of people. Now, how do these various different factors that we've talked about, so things like income, discrimination, all of these, how do those actually impact health outcomes? Well, firstly, they impact how a government can prevent the spread or contain the pathogen. So what I mean by that is that if you identify certain groups, maybe with certain socioeconomic characteristics that are more at risk of a disease, then you might realize that different approaches might be more useful to prevent the spread of that disease in particular individuals, particular communities. An example of this is that exposure to HIV has been found to vary pretty significantly based on ethnicity. So this was a study here in Canada from PHAC. And they found that different ethnicities were exposed to HIV differently. So specifically among whites, for example, it was more prevalent, more likely that people were being exposed due to men having sex with men. Compared that to Indigenous ethnicities, so here in the red, those community members tended to be exposed to HIV instead through intravenous drug use. So PWID is people who use intravenous drugs. Compare that again to members in the study who identified as Black. So people who were exposed to HIV who were Black were predominantly exposed through heterosexual contact. So these are different types of exposures that result in the same disease status, right? So these were all individuals who tested positive for HIV. But because the exposure is happening in different ways, public health would say it's important to know this kind of difference because it can really help public health practitioners design different prevention strategies. So for example, if they knew that they were trying to target a community specifically in an LGBTQ community, maybe they would really want to focus on safe sex education, different types of strategies to prevent HIV spread from that type of exposure. Compared that if they were working with an Indigenous community with high HIV rates, maybe they would want to really focus on something like a safe needle exchange or other types of strategies that would really target intravenous drug use. So from that perspective, it is viewed as a positive thing to be able to access this type of data, this type of race-based data. However, it's also viewed as quite controversial. Why might that be? Why do you guys think it could be controversial to use this kind of data on an ethnicity basis or a race basis? Emma Kate says making generalizations. Yeah. Creates stereotypes. Absolutely. Anyone else? And why are these generalizations or these stereotypes so problematic for these particular community members? It further marginalizes them. Yes, exactly. So these are already communities, whether they are LGBTQ or whether they're Indigenous or whether they identify as Black, these are already communities that are facing quite a bit of marginalization in society. And so to be able to sort of make these claims that the entire group of them is more at risk in one way compared to another way, it does set it up for some perhaps discrimination. They're vulnerable to begin with. Yes, exactly, Abby. So it can be certainly controversial from that perspective. Now, another way that they impact health outcomes is that they impact how patients actually receive a treatment for the disease. So as we know, access to medicine for HIV is fairly common now, but certainly in the year 2000, for this particular map, it was not that common. So it was really only a few kind of more industrialized high-income nations that had access to HIV antiretroviral medication. Now, fast forward that to 2017, luckily access to these medicines to treat HIV and to increase survivorship with HIV have increased. So they have become more widespread. However, it is still unequal. So certain countries have far more access compared to others. And this does often stratify based on high income countries compared to low income countries. And so, countries that can afford it are certainly providing better care to populations compared to those countries that don't. Now, a third way that this can impact health outcomes is that it impacts how a society will actually react to a disease. So what that means is that they could further discriminate based on socioeconomic status as well as disease status. So kind of related to what we were talking about with HIV. Now, another example of this happened with Ebola survivors and the stigma that many of them faced in many West African nations where the Ebola outbreak took place back in 2014. And so what happened there is that in those particular countries, countries like Liberia, where the Ebola outbreak happened, poorer individuals, so low-income individuals, were the ones that were mostly impacted. These were individuals who also tended to have less education. And so for many reasons, economic reasons, it increased their risk of infection of Ebola because of whatever work they were kind of doing. They also tended to have larger households, but also they tended to use traditional burial practices, which really increased their risk of coming into contact with the virus that had already maybe taken a toll on other family members. And so this resulted in a lot of stigma, even among those Ebola survivors who had lived, who had survived, because they were already sort of being treated as these outcasts in society. They tended to be lower income people. They tended to have less education than some of the individuals who weren't as impacted by Ebola. And so, this resulted in sort of a double discrimination, both for their socioeconomic status and as well because they had been branded as these Ebola survivors. So they had a lot of stigma from that. Now, with the last 10 or so minutes, I want to address some of these socioeconomic determinants that we've been talking about and specifically look at them through the lens of COVID in Toronto. Because luckily there has been quite a few good research done here. So I think many of us have probably heard this kind of saying, or in maybe some other words, but generally that we're all in the same boat, that we'll get through this alone, but together. But hopefully after today's lecture, maybe you're starting to think about that and think, well, maybe not so much, maybe not really. We are all in this together in that we're all facing these risks of disease, but we're not all facing them equally. So taking a look at the global case fatality of COVID-19, it did vary quite significantly by country. And these are mostly OECD countries, but even among the high income countries, there were some discrepancies. So factors that accounted for most of these differences were mostly those types of individual factors, things like age, especially, did really have a high impact on the case fatality rate in a country. Some other factors that I think most of us are now familiar with, having spent almost a year now with the pandemic. So, health status in terms of whether someone had cardiovascular disease, whether that cancer, chronic respiratory diseases also significantly impact the case fatality rate. And in case we need a refresher, the case fatality rate is just the disease severity. So it's the proportion of deaths from a certain disease compared to the people with that disease. So it just means how many of them died from the disease out of the people that had the disease. So another sort of factor that I think most of us are familiar with COVID is that people who smoked, particularly people who smoked that were of older age, they also tended to have a higher death rate, a higher case fatality rate from COVID. But some other factors that have been studied or that are starting to get studied now are things like national GDP per capita, as well as the level of democracy. So I was looking at a study that found that more democratic countries tended to fare better with COVID compared to non-democratic countries, but also things like smaller number of hospital beds per capita, which is something that we'll talk about in a few weeks when we talk about healthcare systems. So certainly the healthcare capacity of a country, which is very closely linked to the national income of that country, would play a role in how a country would fare with something like COVID or any other sort of large-scale infectious disease outbreak. Now, taking a look at the incidence rates in Toronto, it started to emerge that lower income neighborhoods were the ones that were being disproportionately impacted by COVID. So the lowest income quintiles were the ones where the rates seemed to be highest. And this is specifically at the neighborhood level. So why do you guys think that the incidence rates for COVID were higher in these lower income neighborhoods? And certainly this type of relationship could probably be witnessed in other cities, but luckily Toronto has done a lot of work with this kind of data. So what do you guys think? Why is it the lower income neighborhoods that are so impacted? They can't afford to not work and stay home. Maybe they didn't have the option to work from home. Economic and social determinants of health. Yeah, exactly. So hopefully, based on some of the things that we've been talking about today, that's probably pretty clear. So yeah, many of these people were not able to stay home if they were sick. Maybe they didn't have access to something like testing, and we'll talk about that. Possibly crowded housing. Yes, exactly. So lower income individuals, especially in neighborhoods where this has been happening, are ones that tend to have large families living in these tiny 1 to 2 bedroom apartment buildings. Not the best conditions if you're trying to contain an infection, but unfortunately, that's sort of the reality for a lot of these lower income individuals who live in the city. Now, another reason that has been explored is this idea of paid sick leave. And so this was an article that I came across in the Toronto Star that was using labor force survey data. And so they found that of the people who were taking paid sick leave during the pandemic, so between March and September, when they were looking at this data, the ones who were receiving that paid sick leave were mostly the higher wage earners, right? So these were generally people who could afford to take that sick leave, who could afford to take a bit of a pay cut because they're already earning a pretty significant amount of money. Compare that to the lower wage earners. Significantly fewer of them were taking that paid sick leave during the pandemic because, of course, most of them have to work. They don't have the ability to sort of sit this one out for a couple of weeks. They really do rely on their income just to be able to make ends meet. Now, this can also be explored through unequal access to tests because prior to the beginning of October, when Ontario moved to appointment-only testing, so prior to that, testing meant that you usually had to wait in a pretty long line, particularly once September hit, and many people from schools were also starting to access testing sites. This resulted in huge delays, huge queues just to be able to go access a test. And so what was the result? Well, perhaps quite obviously, in neighborhoods with the highest percent visible minority, so that's the blue here, as well as the neighborhoods with the lowest income, so that's this red line here, those were the ones that saw a significantly lower number of tests performed by residents or of residents in those neighborhoods. So again, probably for some pretty obvious reasons, those are people who were not able to take off an entire afternoon from work just to go wait in line to go get a test. Maybe they were scared to get a test because, God forbid, if it came positive, then they would have to miss work for 2 weeks. And that, again, is really, really hard for lower income individuals to deal with and to sit out for 2 weeks. Now, this is also a pretty interesting graphic that came out after the holidays. And so this is the map here of the proportion of people in each neighborhood who traveled during the holidays. Now, for those of you who aren't very familiar with these particular neighborhoods in Toronto, I've included a map of household income. And so as you can see, it was mostly the higher income neighborhoods in Toronto. So in sort of central Etobicoke, as well as Midtown Toronto and Eglinton, Davisville, these sort of areas that are higher income. Those were the ones that typically saw the most travel during the holidays between December 23rd and December 30th. And so even though there's no evidence to suggest that these travelers were the ones spreading the disease over the holidays, we just simply don't know that. However, it does show that perhaps these unequal impacts of COVID, right? These are probably people who are mostly working remotely from home. They're probably people who have cottages up north who were able to go up north and escape the city during the holidays. And so it just kind of goes to show how the impacts of COVID are really different among different individuals, particularly when you're examining these socioeconomic factors. Now, this is also going to play out at the global scale. So higher income countries are, of course, starting to think about vaccines and making sure that they have adequate supply of vaccines for their populations. But something that has been started to be discussed now is the fact that a lot of these lower income countries are being left behind. And so it's not going to make controlling new strains of the virus very easy if many other countries in the world are not even starting to vaccinate their populations. And so I think this is probably going to be a problem for next year or later this year for kind of global leaders to start to tackle, because if we really do want to have an impact on vaccine efficacy and also lowering numbers on a global scale, then we really do need to make sure that vaccines are equitably distributed. So I just want to end here today's lecture with a brief reflection on these infectious diseases that we've talked about and how most of them really are preventable in today's scenario, right? Many of them are vaccine preventable. Many of them are also curable with antibiotics, so things like syphilis that we talked about, also tuberculosis, and yet many of them persist. Arguably, there's really no good reason why a country like Canada should have such high rates of tuberculosis in certain communities, right? It's not really conducive to the high income nation that we are, that a part of the population would still be struggling with an infectious disease that is largely preventable. And so hopefully after today's class, these impacts from these socioeconomic factors are worth reflecting on and worth sort of considering in terms of our own perhaps privileged status in society, the fact that we're all going to be university educated and how that might separate our health outcomes compared to other people who maybe don't have the same privileges, the same socioeconomic standing that we do. So I'm going to end it there. And you guys are free to go. Let me know if you have any questions.